Hi, John. Can't hear you. Hello. Hi, John. Just a minute. I have to do something to the volume. Hello. John, you are muted.
Can you hear me, Abby?
Yeah. Now we are good. Hi, John.
I don't know why, man. I'm recording this. Oh,
I think
maybe it's my.
just a minute. I
Okay.
have to do something to the volume.
Okay, I know where it is. Okay. I got so many volumes here. So, Abby, let's see how it goes.
Yeah. Let's see how it goes.
Yeah, what I'd like to do eventually is to get the viewers to go to YouTube to watch the proceedings. But people aren't used to that, you know. But I tell you, YouTube has a really good chat box. Do you know what I mean?
Yeah.
And you can actually watch it without coming into the Zoom.
Yeah.
Because you got to be realistic. Most of the people that come really don't participate. You know, they watch, which is fine. They're welcome.
Yeah.
But they could just as easily do it just going to YouTube to watch it. And you can make comments too on YouTube.
Yeah.
So you don't have to manipulate getting into Zoom.
Yep.
But I think that'll evolve. But unless Zoom, I think, wakes up a little bit and makes
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 it
a better chat, you know, when you ask questions. You know, some guys like Atul Goel, they look at the chat, you know.
Yeah.
And they can prioritize the questions. And which of course we'll try to get you to do
Yeah.
for free.
Yeah.
Well, your check is in the mail.
Hang on.
Hey, I tell you, I was surprised to get that letter from China. That email about they're not starting, but they want to make well known their English version of the Chinese Neurosurgical Journal.
Okay.
Which is great, because that'll give us a lot of speakers. A lot of speakers.
Huge number, huh?
Huge number. Of course, we won't use them all, but I mean, I think we'll have the option to ask them.
Yeah.
Can we have some good neurovascular speakers? You know.
Yep.
And it would be, as a conference organizer, it would make my job a lot easier. And you could more quickly put it, like you could say, okay, next month we're going to have a webinar on brain tumors. Boom, you'd have your roster full in like a couple of days.
Yeah.
But we'll see how that goes.
Yep.
And you're welcome to come. That's next Sunday night. As a matter of fact, this time, next Sunday night.
Okay.
So, did you go to Latin America too, or no?
No, I didn't go. I did not.
Okay. Yeah, I was surprised to see him at both.
Yeah.
And you know, I didn't even bother them about.
After a long time, long travel.
Three weeks, right?
2 weeks, 2 weeks.
Yeah, that's too long of a trip just to go for a week.
Yeah.
And 1 day travel, 1 day back. I went to Nepal once.
Yeah, that must
Yeah.
have been a long trip for you.
Yeah. Spent the night in Istanbul airport. You know they have a they don't have a hotel in the airport, but they have big rooms where you could sleep. No, really, people just go and lay down and take a nap and get up and leave.
Yeah.
It's great. I've never seen that in any airport.
Yeah, I know.
Yeah, you have a couple hours between flights. You'd love it to take a nap.
Yeah.
It was great. And I think you could even shower there. They had showers, good towel, soap and stuff. So makes those layovers useful. I didn't even bother Bogota or Rio. I don't think Lewis even live streamed it from Rio.
No, it was not live streamed.
Yeah.
Yeah.
I didn't bother them because I think they just want to kind of get away from Zoom.
Zoom, yeah.
Yeah, they didn't want to hear about it, so I just didn't say anything. I think they would have come to me if they wanted to, I think. But we're doing one from Mexico City at the end of this month. The
Okay.
pediatric neurosurgery. It's in English, I think it's in English, if I recall. I don't recall. It may be in Spanish.
Okay.
I televised it before.
Yeah.
We're interviewing Bipin next Sunday before this. You know, Bipin of the neurosurgery cocktail.
Yeah, Bipin, right?
Yeah,
Yeah, Bipin Chaurasia. Yeah.
yeah. We're gonna try to do the same thing with him, Q&A with him.
Yeah.
But I found it. I've interviewed him before, and he has it's a good story about how it started and how he had to take care of it.
Yeah.
He had to do a lot. I mean, he had to sleep next to a smartphone, I think, because he had to do a lot. Initially, he had to do a lot of editing because people would post all kinds of stuff, I guess. And so, as a trainee, God, he was on call for neurosurgery cocktail and neurosurgery.
Yeah.
Because you'd hear a beep, when someone posted something, there would be some kind of warning for him, and he'd go check it. And that's why it got a reputation. I mean, it's the best.
Yeah.
You always look at that, right?
Yeah.
Yeah, I think everybody does.
Yeah.
It's a very good information site. He's letting us post about the conferences too. But maybe, Abby, we can get the real story behind it.
Yeah.
The dark, seedy side of video broadcasting. The hidden world of scandal.
You'll get it out of him, don't worry.
Oh yeah. We'll have an hour show.
Yeah.
Oh, here's the tool. There's the king. You're not Your audio is not working, Atul. I don't know why.
Can't hear you, sir.
Let's see. Let me check. You may not even have.
Now you can hear me?
Yeah, we can hear you now.
Yeah. Hi, John.
Wow, man, you were gone for, Abby says 3 weeks.
Yeah. You know what, John? I was in Colombia, in Bogota, and so many people knew me because of this, because of the webinars and all.
Oh, really?
Unbelievable. Everybody,
So they talk to you about it and they learn stuff and they,
Absolutely.
Great.
And
So they knew what you were talking about before they even met you.
Yeah, they knew me very well.
Good. That's great. That's great. And of course we have one with the Chinese next week.
Yes.
I think that's gonna open some doors, Atul.
Yeah, I know.
For them to reach out for the Western world to send publications. I mean, that's the first step. That's a great step.
Of course.
So, the neurosurgery world will know, I think, how important that is. I think
that's right.
And you know, you've been to China probably many times, right?
Yeah. China.
Yeah,
China
you know
is
people there.
Of course.
Yeah. So yeah.
You think we can? I can communicate this to some people in China?
Yes, we're going to do that. We're going to do, hopefully, I'm hoping that it's going to open a lot of possibilities for televising neurosurgery because there'll be English-speaking Chinese neurosurgeons presenting. So then that adds for, like I was telling Abby before we started, for a conference giver, it makes it a lot easier because all of a sudden it'll double the possible speakers.
That's right.
And some of them we won't know, but we'll hopefully get to know them, in certain fields like spine, like atlantoaxial junction, communities in that, that they'll be there.
Of course. I can see Dr. Harshad Parikh online. Harshad, you are there?
Yes, Atul, looking at you.
I want to look at you. Put your video on.
Yes, my video is on now.
Yeah.
Are you in the hospital, Harshad? How you doing, Harshad?
No, I'm at home.
Okay. Oh, okay. Comfortable at home.
Yeah. Atul had a great meeting at Colombia and I think Brazil, Rio.
Yeah.
He was a master. He invited to give some demonstration of surgery there.
I did 2 operations in Rio.
Yeah, what are the cases you did?
Oh, Lewis was live, more live than.
I did 2 cases there, Harshad. One was craniovertebral junction, one was cervical spine.
Wonderful. I asked you for a link, but you said, let me see, but it didn't come up. I wish. I believe Pragnesh Bhatt you met in
Yes.
Colombia.
Pragnesh. We had a good time together with Pragnesh.
Yeah. Pragnesh has got a big mustache now. He looks fantastic having that mustache.
You know, Atul, I have one question. How did you like the food? Because it's so different in India. It's so totally different than America too.
Not only food, the whole thing, John, the culture, the beach culture, is different. India is different world, and Colombia, Brazil, different world, different. Brazil was, too good, fantastic.
Yeah, that city is amazing, real. And I went there thinking I could speak Spanish there. Portuguese is different than Spanish.
Portuguese is completely different.
Yeah, I thought everyone could understand me. Spanish, it's similar, but no, it's not that similar. It's not like English. English and Spanish are very similar, but Portuguese and Spanish are not.
Yeah, yeah, yeah.
So, okay, you ready to start it too? You want to wait a few
Yeah.
minutes? You want to start?
No, I can go. I can start slowly, maybe, or maybe I think let's begin, or maybe after 1 minute. That
Yeah,
may be
sure,
better. Yeah.
sure. So you love Rio, huh?
Yeah, wonderful city. Wonder. I have been there, Rio, earlier, but this
Oh, you've
time
been there
I,
before?
yeah, yeah. But this time I was, staying in a fantastic hotel across the beach, and
In the Copacabana or Ipanema?
Copacabana was close by, so it was fantastic this time.
Yeah, everyone in Latin America told me about the dangers of Rio when I went there. But I just stayed to the main street, the main, that main street that goes by the ocean.
There are no dangers, my dear.
Yeah, I just stayed there. I didn't really go out at night, and so there was no problem. But the two cities I put in the same class as Rio are San Francisco and Paris. Those are to me, they're the three most beautiful cities in the world. Okay, Atul, you ready to start?
Yeah, yeah.
Okay, let's go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett, broadcasting from Miami Beach here in Florida. We have the honor of having who I call the king of Zoom because he travels everywhere to give these Zooms. And the neurosurgery world thanks him. And I'd like to introduce Atul. Right now, we're going to try to make this interactive, and I'm sure Atul will talk about that because I just got the impression when I moderated a lot of Atul's talks that people wanted to kind of talk to him because he seemed to generate more activity. So we're going to give it a shot today. And welcome, Atul.
Thank you, John. And I'm happy to share some of my recent work on, you want me to talk on spine. So spine, you know what, John, I've spent all my life in cranial surgery, in skull-based surgery, in complex skull-based surgery. But spine is special. And spine, you can, if you understand spine, if you treat spine properly, you create wonders and you give new life, and absolutely new life. So let me begin. Before I begin, I have to thank John for giving me some wonderful titles and organizing this beautiful show. And I hope and I wish and I want that this revolution in spine, which I call absolute different spine, the message goes far and wide and loud and clear. Okay, John, let me begin. So
Yes,
I'm
please,
going.
please.
Okay, John. So the first sentence that you see on my slide show is that I want to talk on something new on spine surgery, something which is absolutely different from what is conventional. And I want to talk on beyond decompression. If you are a spine surgeon, the first thing that comes in your mind is compression. And the second thing and the main thing that comes in your mind is decompression. So I'm going to show you something beyond decompression. My concept is clear that compression is never an issue and decompression is never a treatment. So this is a very huge statement in spine surgery. So what I'm going to do is I'm going to talk for first half an hour on craniovertebral junction, which many of you know is my very favorite subject for a long period of time. And then I will leave the house open for questions. And after a few questions, I will go on to the rest of the spine for another half an hour. And then the whole House will be open for further questions. You think, John, that is a okay format?
Yes, it is.
Okay. So new spine surgery. So you tighten your seat belts and be ready for something which you probably have not imagined. Many of you have heard me, and they will certainly like to hear me again. So I'm introducing a new concept. I am introducing an absolutely different concept. That compression, you don't go for compression. Compression is never primary. Compression is always secondary. Compression is always protective. And compression is always reversible. So this is the concept. And instability is the issue. And stabilization is the treatment. So with that concept, I'm going to take you further, first on craniovertebral junction, and then on rest of the spine. So the issue is, you see, we human beings are the only animals on the planet where we stand. And our entire body, the musculature of entire body is on the posterior aspect of the body. There are no muscles in the front of the abdomen, in front of the vertebral body. There are hardly any muscles. And these muscles make us stand and make us work. Unlike other animals where, like horse, there are 4 legs and shoulder muscles, there is not much weight on the spine. Similarly, on this bird, it is on the shoulders that work. Here, shoulders, of course, are strong in this fantastic picture, but what is more strong is the spine. Horse may not get any spinal issue any time in the life. Similarly, this bird may not get any spinal issues. What issues is, because wherever there is an activity, there is a problem of trouble. Wherever there is more activity, there is a problem of more trouble. So these spinal muscles, the weakness of this muscle, abuse, disuse, injury is the cause of problem, the cause of various problems in the neck, in the craniovertebral junction, and in the spine. So I have introduced this term, which is first time in the literature, the term of vertical facetal instability. Vertical means standing, and I have shown you this telescope where I'm saying there is a telescoping of the spine due to the weakness of the muscle, which is the cause of various issues and the point of genesis of spinal spondylotic disease. So I will touch on this later. All the muscles of the spine act on the facets. Vertebral bodies and the disc, there is nothing much attached on these structures. The entire activity of spine is focused on the facets. And when the muscles become weak, there is problem at the facets. So this concept is different from what is in the literature. The whole world of spine focuses on the disc. My concept is absolutely clear that disc is never an issue. Disc is divine, disc is God, disc is never a problem, it is always a solution. More the movements, more the possibility of abnormal movements. You see, this is the spinal column. There are movements at each level, each segment, but this craniovertebral junction is the most mobile segment of the body. More the mobility, more the possibility of abnormal mobility or instability. So craniovertebral junction is the most unstable spinal segment. I have to say that atlantoaxial joint is the most mobile joint. Atlantoaxial instability is the most common form of instability. And I have said on several forums that atlantoaxial instability is the most under-treated instability in our subject of spine. Most under-recognized and under-treated. I'm not sure how many of you know in the audience that basilar invagination is a common disability in spine, and the whole world was treating basilar invagination by decompression. The question of instability was never raised. About 20 years ago, nobody talked of instability in basilar invagination. Group A, which I mentioned here when I divided this basilar invagination into two groups. Group A was where transoral decompression was done, and Group B, where the tonsil came down, foramen magnum decompression was done. Essentially, the concept was that compression is the issue and decompression is the treatment. Because the instability is fixed, decompression was the treatment. In 1998, I also recognized this fact of decompression, and we published this very highly cited article. In the year 2004, we identified for the first time in the literature that Group A is an unstable region, and this Group A needs stabilization. Group B, in 2004, my concept remained that Group B, there has to be decompression. So we introduced this term craniovertebral junction realignment for this Group A. And we said that you can realign and stabilize. Facetal instability is the cause. C1, C2 instability is the cause of basilar invagination. This kind of basilar invagination, where transoral surgery was the only treatment that was indicated at that time, we introduced the fact that you can realign the craniovertebral junction and stabilize without doing any kind of decompression. And this concept is now very well known throughout the world. So there is basilar invagination. We introduced the fact. This was my first case in the year 2000. So we have got now several hundred cases, and many people in the world are not resorting to decompression now and doing this kind of operation. And there are many groups in the world, and in India and in China and various countries. So this is basilar invagination, realignment, stabilization, realignment, stabilization. So you can see from my slides here, what I've shown is that I do stabilization, I do realignment, and I want to achieve arthrodesis or stabilization or fusion. But as I matured further in the business of these problems, I have realized that more than realignment, stabilization is the solution. Instability is the problem. Stabilization is the treatment. Realignment may be achieved, but that is not the primary goal of treatment. This kind of rotatory dislocation, which many of you have now familiar with these faces, which I show on all my presentation, rotatory dislocation, the only treatment in the world was decompression, or some people resorted to halo fixation and things like that. We introduced the concept that you can mobilize and open the joint, realign the craniovertebral junction, manipulate the facet, and you can make the neck straight. So we have got now several hundred patients with these kind of problems where we have not done any kind of decompression. And I can only tell you that if you want to get such happy faces, you have to do stabilization and manipulation of the facets. So these kind of issues, this kind of head and these kind of faces. This kind of dislocation following trauma, there was no other treatment but decompression. So open the joint, realign the craniovertebral junction, and do realignment, stabilization. So decompression is not there. Many of you may not know that about 20 years ago, there was the atlantoaxial instability was divided into two groups, fixed and mobile. And the whole world was recognizing this. And whenever there was a fixed dislocation, decompression was the treatment. But we introduced this concept of reduction of fixed dislocation, and this has completely revolutionized. There was no question, complete revolution in craniovertebral junction surgery. So in flexion and extension, this remains like this. So there is no need for decompression. You can open the joint and realign the craniovertebral junction, open the joint and realign the atlantoaxial joint. Another issue I don't want to, I want to just summarize my thoughts in this presentation. Earlier, we used to do occipito-axial fixation, but now I have to say all craniovertebral junction instability is atlantoaxial instability, and all craniovertebral junction stabilization is atlantoaxial stabilization. So essentially, we said that instability is the cause and stabilization is the treatment in both groups A and B as we matured further. And transoral surgery and our transoral decompression is a completely historical operation now, in my view. And there is no question that this operation should never be done, no matter what. So this was the concept that atlantoaxial instability or listhesis is the issue of basilar invagination, like lumbosacral listhesis. You treat, as you treat lumbosacral listhesis, you treat basilar invagination. And we treat it like this. So this is listhesis. This is listhesis. Open the joint, correct the listhesis, and realign the craniovertebral junction. There is no need for decompression. Then came a very fantastic, and this is about 13 or 14 years ago, we introduced this complete revolution. I have no hesitation to say complete revolution in craniovertebral junction, complete revolution in cervical degeneration, complete revolution in OPLL surgery, in Hirayama's disease, and so on and so forth. I will discuss with you. The issue of central atlantoaxial instability, complete revolution. Now you see this slide very carefully, very favorite slide of mine. The whole world of atlantoaxial instability was focused on atlantodental interval abnormality and C1 over C2 listhesis and cord compression. Listhesis is the issue and stabilization is the treatment. So this is type 1. Now you see type 2. Type 2 is there is no atlantodental interval disturbance, there is no compression, but there is basilar invagination, there is carry, there is syrinx, and there is facetal malalignment where the facet of atlas is behind facet of axis. This is completely unstable. There is no need for decompression. There is need for atlantoaxial stabilization. So this is when there is no atlantodental interval disturbance, even then there can be instability and there is a need for stabilization. Type 3 is when there is no atlantodental interval disturbance, there is no facetal malalignment, but presence of tonsillar herniation, presence of Siringo Myelia, presence of assimilation of atlas, presence of platybasia, and all these things are indicators of chronic atlantoaxial instability, and atlantoaxial stabilization is the treatment. So now I'm introducing a new concept, chronic atlantoaxial instability. When there is a chronic atlantoaxial instability, there are several reparative, natural, divine, reparative issues which come in picture, and basilar invagination, all these things, basilar invagination, short neck, torticollis, bone fusions, platybasia, Chiari malformation, Siringo Myelia, they are all secondary manifestations of chronic atlantoaxial instability. So when there is chronic instability, you have secondary natural protection, and all these secondary issues, which may even be compressive, are secondary, they are protective, and they are reversible. So this concept has completely changed the entire scenario of craniovertebral junction. And we have got several articles on this subject. For both group A and group B, there is only treatment of atlantoaxial stabilization. So this is the concept which we changed over the period of time. So when there is Chiari and syrinx, you see these slides, there may not be any atlantodental interval disturbance. There may not be any major facetal malalignment, but this is clearly indicative of atlantoaxial instability. You stabilize and you see the magic. So now my concept is absolutely clear. Chiari malformation is secondary to chronic atlantoaxial instability. Syringomyelia is secondary to chronic atlantoaxial instability. They are secondary, they are protective, and they are reversible. So you see the syrinx goes down on a regular fashion. So even when there is no atlantodental interval disturbance, no facetal malalignment, presence of tonsillar herniation is an indicator of atlantoaxial instability, and stabilization is the treatment. So we have got now several hundred cases where this kind of Chiari and tonsillar herniation, where I used to personally do foramen magnum decompression and all those things, syringostomy, syringo-subarachnoid shunts, completely not necessary, completely negative operation. This is due to atlantoaxial instability. You stabilize and you see the magic with the clinical situation, with the radiological situation. So you see, this is another patient with preoperative. This is immediate within few days of surgery, and this is delayed after a few months of surgery. The syrinx will go. Syrinx goes or not, that is not the issue. Patient will remarkably recover after surgery. So we have got several articles that you can see on the screen, and you might like to read them. And I have to say for sure that this mystery of Chiari is completely solved. This revolution of Chiari is completely made and clear. Atlantoaxial instability is the cause, and stabilization is the treatment. So more recently, I published my series of 388 cases where we did only stabilization without the need for any kind of decompression. And even in children, some people had said that this may not work in children. This works 100%. Some had said that this works only in basilar invagination. No question, basilar invagination is the brother of Chiari malformation. Syringomyelia is the brother of Chiari and basilar invagination. They are all children of atlantoaxial instability, and atlantoaxial stabilization will treat the major genesis of the entire issue. So these are protective, these are secondary, and Chiari malformation should be called formation because it is not abnormal, it is protective, natural airbag. So what happens in chronic atlantoaxial instability, nature or God comes in play, and there are several reparative or naturally protective mechanisms which come into play. Now, cervical fusion in clipal file abnormality, cervical fusion is not an issue. They are secondary, they are protective, and it is due to craniovertebral instability. You do not do anything to the fusion. What you do is to atlantoaxial instability. Similarly, bifid at anterior and posterior arch of atlas. It is not bifid of spine, lumbar spine, it is bifid of atlas is a protective natural phenomena due to chronic atlantoaxial instability. There is no need to deal with this bifid. What you have to do is atlantoaxial stabilization. So there is fusion, there is bifid, there is no compression. So I am saying and absolutely clear in this concept that compression, you should not even bother. You should not even look. You should identify which segments are unstable and you stabilize. And you see the magic of the treatment. Os odontoideum is also, see, whatever statements I am making are all published. When I say protective, natural, and all those things are published in these journals. So os odontoideum, I am saying, is also a natural protection, and it is an indicator of atlantoaxial instability. You have to stabilize the atlantoaxial joint. You don't bother about decompression, and if you bother about decompression, you are certainly harming the interest of the patient. You have to do atlantoaxial. I have, this looks very simple, but I can tell you that several places in the world still decompressions are done for this problem. Occipitoaxial fixation is done. Both of these things are completely, absolutely negative kind of operation. Syringomyelia is also secondary and protective. So nobody knows what is the treatment of idiopathic syrinx. Nobody knows. Syringostomy, shunt, and all those things. There is no compression, so there is no decompression. Compression is not the issue. Issue is unstable atlantoaxial joint. Stabilization is the treatment, and magic is the result. Long-standing musculoskeletal abnormalities like short neck, torticollis, and all these things are secondary to atlantoaxial instability. They are secondary. They are protective. This kind of short neck and muscle spasm and torticollis are secondary, protective, reversible following atlantoaxial fixation. You see, reversible, and this smile is permanent. This smile, unfortunately, has not come here, but this neck length will permanently remain in this situation. No need to touch or decompress. Fixation is the treatment. And there are several patients like this. So short neck, we know short neck. We don't know short head can also be there. Short spine can be there. Short body. And these are all hallmarks of basilar invagination. And they're all secondary to chronic atlantoaxial instability. So this concept is quite a big concept. I also introduced the term external syringomyelia. See this water. One concept you must remember, that this can never go wrong. Water can never go wrong. Syrinx is water. Water is life. Syrinx can never be bad. Syrinx is a solution. Nature can never be wrong. Tonsils can never be wrong. What is wrong is this weakness of the muscles, which we should treat. So this presence of extra fluid outside the spine is also external syringomyelia that we have labeled, is a protection, is a natural protection. Like, so you see here, there is internal syrinx, there is external syrinx. Internal syrinx, external syrinx. So both internal syrinx and external syrinx. You see, this is external syringobulbia. There is no tight fossa. There is no need for decompression. These are indicators. All this, if there is extra fluid, it indicates the presence of atlantoaxial instability. Short spine, you see short spine, like short neck. When there is short neck, there is torticollis. When there is short spine, there is kyphoscoliosis. For this, kyphoscoliosis is not primary, it is secondary, it is protective, it is natural, and it is reversible following atlantoaxial. Now we have got several patients like in this age group in particular, where there is no need to fix the subaxial spine. There is no need to introduce several screws and all those things. What is required is atlantoaxial instability, and what you get is a magic. There is no question about that. You see, when there is syrinx and when there is atlantoaxial instability, you are seeing Chiari, then there is no question. Even when you don't see these things, you will find central or axial instability, and that needs to be treated by atlantoaxial. Nothing to be done for this. And this smile that is hidden will be absolutely permanent and glorified. So you see, these kind of children, you can give new smile if you understand. And central or axial instability is a complete revolution. It can by itself cause cervical myelopathy. Now you see this patient, there is no compression at the atlantoaxial joint. There is some syrinx here. When there is syrinx, when there is extra fluid outside the spinal cord, it indicates unstable spine, and it indicates the need for stabilization. There is bifid, there is no compression, but there is bifid. It indicates the need for atlantoaxial stabilization. There is kyphoscoliosis in presence of central atlantoaxial instability. You have to include atlantoaxial joint in the fixation construct. And you see the magic. This hand was not going up. This is in the post-operative period. The shoulder was not going. This is in the immediate post-operative period. So central or axial instability is a real thing. So can foramen magnum decompression surgery become historical? Absolutely, yes. So now what I'm going to do is, John, I'm going to wait for some time.
That would be great.
And I want people to ask me questions. And then I will go to the next chapter, which is the subaxial spine. So
Okay,
please, yeah, okay, John.
Okay, very good, Atul. Let's see, and it depends on people if they interact. I mean, here's the man you're talking about. the last 30 minutes. So please interact. I encourage you. So the floor is open.
Atul, hello.
Hey,
Hi,
Vlad,
Vlad.
how you doing?
I'm doing fine. I heard this a week ago in Rio, actually. And I fully agree with you. I like it very much because this is really innovative. And I think that you really deserve Krishna Institute Prize. But,
Thank you, Vlad. We have shared this.
do please return the money to IPE.
John.
Just to be a little provocative, Atul.
Yes,
Do you see any indication which is not suitable for stabilization?
See, there are various issues which I have talked about, Vlad, in my presentation, like several issues. You see, earlier only decompression was the treatment. But now there are several issues where decompression may be a negative form of treatment. I am quite convinced over the period of time. So, like Chiari, decompression is the only treatment in the world. But I am saying that for Chiari malformation, decompression is a negative treatment. Chiari is an indicator of atlantoaxial instability, and Chiari indicates the need for atlantoaxial stabilization. So that is the concept, which is quite a huge concept, as you will imagine, Vlad.
Then I believe, what we've seen in Chiari when we did decompressions, that the patients did well for, say, 2-3 years, and then they again started deteriorating, and there was nothing to offer to them.
That's right. That's right.
I suppose that your stabilization is a permanent solution.
Permanent. Vlad, I have now operated several patients of Chiari and Sirings where they were decompressed earlier and they have failed, and I have written about it. So failed decompression is a new operation which I am doing on a very regular basis now. Failed decompression for foramen magnum decompression. Failed syringostomy shunts. So these kind of things. Basilar invagination, of course, now the whole world is doing stabilization, but basilar invagination, the whole world was doing only decompressions earlier.
Thank you.
Thank you, Vlad. And I want you to now, Vlad, also listen to the spine revolution. I want you to give your comments after I finish some questions here.
Sure will. Sure will. Apeja, hello.
Very good. Good to see you, Vlad. Okay.
Great, John.
We have a question from Abdelasan. Why and how is Siringo Myelia protective?
Yes, that is a very important question and very... So what I have said is that syringomyelia is a secondary issue. Chiari malformation is a secondary issue. All these are secondary, these are naturally protective, and these are reversible. So this is the concept. So what I'm saying is chronic instability, when there is a chronic atlantoaxial instability. See, when there is an acute instability, some trauma and things like that, there is spasm in the neck, there is huge spasm and there is stabilization of the neck. But in a chronic situation, this spasm becomes long-standing and the neck ultimately becomes short. So basilar invagination is a part of the whole complex. Similarly, Chiari tonsillar herniation is secondary and it is protective and it is long-standing. And the symptoms are relentlessly progressive. Similarly, syringomyelia, that is what I'm saying, that syringomyelia is water, water is life, water can never be wrong. And this is the concept, syringomyelia, hydrocephalus. It is, now we have to understand hydrocephalus. Some other lecture, I will talk on hydrocephalus. But today I'm talking of syringomyelia.
Do you want another question there now, Atul?
Yeah.
Yeah, Arjun has a couple of questions. Arjun, can you come on live, please? Arjun, are you there?
Yeah, good evening.
Arjun, you can come live. Yeah, you open your video. That is the purpose of this, he has organized this special seminar because you can come live on this and ask your question.
Go ahead, Arjun.
Good evening, sir. It's a pleasure to have you see a talk here, and that too on a subject that is very close to you, and you have been a pioneer in this subject. First of all, heartiest congratulations again for this talk, sir. And I had a couple of questions, sir. So now, sir, I feel that it's quite a high time now. We should introduce all these concepts that you have told just now to incorporate for criteria for atlantoaxial instability, because still clinically on a radiological parameter, we just see atlantodental interval right now for atlantoaxial instability, even for any clinical practice that we do right now.
Right.
So,
Arjun, before you go further, let me answer this question. The thing is, the only parameter of atlantoaxial instability currently is atlantodental interval disturbance. There is no other parameter.
right.
And, sometimes compression can be taken as instability, but the parameter is atlantodental interval disturbance. So that is what is a revolution. Revolution is that there can be instability without evidence, radiological evidence of instability. There can be chronic, long-standing instability without radiological evidences. Now, these radiological evidences like Chiari, like Siringo Myelia, like osteophytes in the subaxial spine, like bone fusions, when you see these are indicative of instability. And these are indicative that you do atlantoaxial stabilization. So this is a criteria, no question. I agree with what you are saying.
Another thing that I would like to point out is, sir, for us as young neurosurgeons, how would you advise going for an intraoperative reduction? Like, definitely I've seen you operating, but for people like us who will be starting to operate, so doing an intraoperative maneuver, how do you advise us to go about that? For an atlantoaxial reduction, where even the facets are malaligned and you have vertical facets, and then how do you go? How would you advise for the young neurosurgeons?
See, facetal manipulation, you see, the most important thing is, now for the young neurosurgeons, let me say some things. I am saying that we, not only neurosurgeons, there are some orthopedic surgeons also in the audience, Arjun. So I will talk to spine surgeons in general.
Right.
I have to tell them that atlantoaxial instability is a commonest form of instability of the spine. And atlantoaxial surgery, fixation surgery, should be learned by everybody, should be learned. And if you are saying that I don't want to learn atlantoaxial fixation surgery, you will lose out on a lot of spine. John, there is some noise in the thing. Can you just, can you see?
Yeah, let me see. Okay.
So if you say that I don't want to learn atlantoaxial fixation surgery, you may lose out on many things which may come in the future. I have no hesitation to say in future, atlantoaxial fixation surgery will be the most common form of spine surgery. I'm telling you. So what we have to do is we have to learn the art of atlantoaxial fixation surgery. We have to learn the art of opening the joint. We have to learn the art of introducing bone in the joint. We have to learn the art of fixation. So more than manipulation, stabilization is important, and more than anything else, we have to learn how to open the joint. And it is difficult, but it has to be learned, and it has to be done properly. Because as you know, that if you don't do it properly, you can have a disaster at hand. Any complication of atlantoaxial instability treatment can be a disastrous outcome, a complication which you will never like to have. Okay. John?
Okay, yes, there are a couple of questions in the chat there. Can you see them, Atul? You want me to read them to you?
No, I will read. Now, there is one question from Garima Srivastav. Could you understand if surgery is recommended for people aged above 60 and above? See, there are, here in the audience, some patients also are there in the audience, John.
Okay.
I don't know how, but they are there. And I have to answer this question. Absolutely, yes. 60 to 70 is no age. And if they have a problem, if they have an instability, it has to be treated. There is no question, absolutely. Okay, that is the answer to you, Garima. Now there is one question from, just a minute, from Vijay Gupta. What to do about osteoporotic atlantoaxial instability? Oh my goodness, osteoporosis and degeneration of degenerative osteoarthritis. These are huge issues in elderly people in particular. You know, whenever I will be talking about it in my next, now after this, I will be talking on this subject. Vijay, you want to come on the screen and ask me this question? That is also a possibility. Abdul Rahim, I will ask you to come on the screen and ask me the question. Can you do that?
Perhaps not.
Okay, so Vijay, I have to say that osteoarthritis, you can give new life to the people. Osteoporosis is no issue. Osteoporosis can occur in the whole spine, but the facets are relieved. The facets are not, you know, they are the strongest bones because they have weight bearing. Facets will remain strong even if the whole spine gets osteoporotic. So osteoporotics, you have to treat by facetal fixation.
I think we have a good question, Abdul, from Abdul Taz, a neurosurgeon from Turkey. Do you want to come on camera, Abdul Duram?
Abdul, you want to come on camera?
Abdul Taz? And see, if not, let me just read his question. Just hold on. Thank you for the great presentation. Do you have any suggestions if syringomy does not regress?
Okay. The question is that if syringomyelia does not regress after stabilization, what is to be done? Now, first thing is, this is a very important and very good question, and I am very happy to answer this question. The question is, if syringomyelia does not go after fixation, what is to be done? The answer is, syringomyelia is not the issue. Instability is the issue, and the patient is the issue. If the patient recovers remarkably, you do fixation, patient will recover remarkably. And if the patient is all right, even if the syringe does not go down, it is not the issue. If the patient is all right and syringe remains there, do not worry about it. Do not worry. Syringomyelia will eventually go. I will say in 100% of time, syringomyelia will go if you do a scan after 1 year. Before 1 year, it may not go. But after 1 year, it will certainly go if you have done a very good, beautiful fixation. Now, there is one more question from Anil Kumar, where he's mentioned, Dr. Abdul Rahim is at the airport, John, so he cannot join. He cannot come on the screen. So that is not an issue. So Dr. Agrawal is asking one question. Sir, is segmental OPLL panning across? Oh my goodness, this question, Dr. Agrawal, I am going to answer this question in the next phase of my lecture. OPLL is one of the most devastating disease of spine. But I will tell you that OPLL is the most beautifully treatable issue if you understand this properly and if you treat it properly. And next time when I talk about OPLL, I want you to come on the screen and ask this question. That will be the next thing. Dr. Ashutosh wants to ask some question. Ashutosh, you want to ask some question? Come on the screen. Video on.
Good evening,
Yes.
sir.
Good evening. Good evening, Ashutosh. Yeah.
Yes, sir. As per my understanding,
No, speak loudly. No, speak loudly.
Can't hear you
as per my
too well.
understanding, you are treating the instability basically, and
Yeah.
According to you, all the symptoms, all the other features, is a manifestation of instability.
Get
So-
closer to the microphone, please. Closer to the microphone. We can't hear you well.
Come close to the microphone.
Okay, sir. Am I audible?
Unmute. Okay, talk now.
Yeah.
Yeah, no. No.
Sorry. You probably have to write the question, Tool. And
Yeah, Ashutosh, you write the question on the chat box. No, I cannot hear. You have to solve this problem, John, that this, we should not lose like these questions.
Yeah, it's too bad.
Yeah. Abida, you want to ask me a question quickly?
Yeah, sure.
Yeah.
Sir, I will like to ask the question after your spine talk. It is more relevant to your spine talk. But in this now, do you see any role of any kind of decompression, transoral, posterior, foramen magnum decompression for any kind of abnormality in the craniovertebral junction? That is one question. And second is, sir, could you elaborate on kyphoscoliosis and craniovertebral junction instability?
Yeah, these are two very, very important questions. You see, now, if you ask me, there is no role for decompression in the entire spine surgery, not only in the craniovertebral junction, but also in the subaxial spinal surgery, which of course I will now talk after this lecture. As far as kyphoscoliosis is concerned, this is a very commonly treated issue in the orthopedic and the spine section. But I have now come to realize that lot of spine kyphoscoliosis in the subaxial spine is related to central or axial instability, and you can treat it without doing any manipulation or screw implantation in the subaxial spine. This is a huge, huge thing. Now there is another question. Let me read it from Dr. Rahul Sagar. My family are confused because one government doctor is saying that I need occipital. Yeah. Now of course, this is a very, many neurosurgeons on the screen, but there are some patients who have also come, John. But I have to say that occipital fixation was the technique which I introduced, screw technique of occipital bone, I had introduced in 1998. But now I am saying that occipital fixation is completely not necessary. Atlantoaxial instability is the issue, and atlantoaxial stabilization is the treatment. Occipital inclusion of the occipital bone is not only not necessary, it is harmful. And it can, not only harmful, it can result in various issues for the patient, like he cannot move the neck, he cannot, turn the neck, and there are several issues. So essentially, occipital fixation is not necessary. So that is the answer.
Do you see the question by Arjun? Arjun, can you ask the question live? It's quite a long question. Go ahead, Arjun.
So
loudly, Arjun.
Yeah, so even we find patients with idiopathic syrinx. So what would be your take on that? As for the craniovertebral junction part, so should we investigate for that matter if they have an idiopathic cervical syrinx? Should we investigate?
This is a very, very important question. Very important question. You see, idiopathic syrinx, nobody in the world knows how to treat. Idiopathic, because we don't understand why there is syrinx. So you don't know how, if you don't know why there is syrinx, you don't know how to treat. So first thing is, you should find out if you can find a cause, like sometimes there is a tumor here and there. Sometimes there can be infection here and there. Some trauma can be a cause of syrinx. If these things are not there, and if it is a classical syringomyelia idiopathic, atlantoaxial stabilization will create magic for the patient, magic.
You had a question, Arjun, about the criteria, global criteria for Atlanto. Could you ask that, please?
Yeah, and sir, maybe when you see the scans and you find that the C2 pedicle is probably less than 3 mm, the cuts you find that it may be hypoplastic and you won't be able to maneuver the screws in well. So what will be your contingency plan in that? Maybe if you find that pedicle is not really the diameter that it should have been more than 3 mm, then
No, there are several other options in that case. You see the vertebral artery is right in the picture, and you have to protect it. So if the pedicle is small, the vertebral artery can come in real danger. So you have to protect you have to find alternative solutions. There are various alternative solutions in those situations, which I have, published on several occasions, and that is a huge chapter in itself, and that can be discussed in some other lecture as well. Okay?
Right.
Sir, what do you, about C2 ganglion sectioning, what do you recommend now? What is your experience now? Do you routinely section the C2 ganglion now, or maybe it is not necessary?
See, I had described C2 ganglion section in 1988. So about so many years ago. And I have written on this subject on several occasions that C2 ganglion lies just above the atlantoaxial joint, and to open the joint, C2 ganglion should be sectioned. But now we have, as we go further in the picture, we realize that there is no need for sectioning of C2 ganglion in almost all the cases. Very few cases now I am doing sectioning, otherwise I am not doing sectioning of the C2 ganglion. Now there is one more, John, there is one patient who is wanting to ask, you think we should?
No, I think we should limit it to medical. What do you think?
Yeah, I agree.
Let's medical to medical. I'm sorry, patients, but this is strictly a medical meeting. Okay, Vijay Gupta asked how to deal with an aberrant vertebral branch at C1, C2 joint.
This is also very, John, there are many young people who are asking these questions, and I'm very happy to answer because they have in mind and they want to know this. And I'm happy to answer this question. See, aberrant artery, whether artery is aberrant or whether the artery is not aberrant, whether the artery is in normal situation or whether the artery is high riding, we have to protect the artery. And if we don't protect the artery and if we damage the artery, we can create a disaster on table. So we have to know the anatomy of the vertebral artery, normal artery, aberrant artery, and all those things we have to know very clearly. And if there is aberrant, we have to manipulate the artery here and there. And if the manipulation is not possible, we have to find alternative solution. So these are the things. Dr. Ashutosh wants to retry, John. Ashutosh, please go ahead now. Can you ask question?
Yes, sir. Yes, sir.
Okay, open your video.
Good evening, sir.
Much better.
Am I audible?
Yes.
Yes, sir. Good evening, sir. Just I want to ask one question. According to your theory, you are focusing on instability, and according to you, all the symptoms and the radiological markers due to instability. Can I ask one question? Your procedure, your fixation can cure the patient or stop the progression of the symptoms?
No. Cure the patient. Instability is the problem. If you want to cure, you see, you do decompression. When I was a student, when I was a when I appeared for examination in neurosurgery, and we were asked the question about what will you tell the patient who is undergoing foramen magnum decompression. So my answer was that I am doing this decompression to stall the progress of the disease and not to cure. That was the answer I was expected to give. So now I am saying, no, that is not the answer. Answer is cure. You will be cured in the evening of operation. These Chiari malformation patients are very disabled. Many of them have breathing issues. Many of them have pain. Many of them have paresthesia. Many of them have various issues. So when they have so many issues, all these issues, breathing issues, sleep apneas, there are so many things which can disappear in the evening of operation.
Sir,
Go ahead, Ashutosh.
Yes, sir. Ma'am, please you continue, then I will ask.
Now, there is one question on the screen. Raghavendra is asking. Raghav, can you come on the screen and ask? Okay, Raghavendra is asking, in case of odontoid fracture is managed by C1, C2 fixation, can the implant? This is also a good question. See, the thing is, Raghav, the question is very good. C1, C2 fixation, when it is done, it is a difficult operation. It is not an easy operation. You introduce screws in C1, you introduce C1 screw in C2. It is a difficult operation, and the aim is to achieve arthrodesis, fusion. And when the fusion occurs, these screws sometimes can be incorporated in the bone. So to remove the screw is not an easy procedure. So if there is a fusion which is occurring after odontoid fracture, the best option is to leave the screw and, don't worry about the movements. I know many people are trying to now do this temporary remove after 3 months to restore the movements. I completely don't agree with that concept. I think that what you have to do is, if there is instability, stabilize. If there is odontoid fracture, which results in atlantoaxial instability, stabilize. If there is a unstable, the treatment is stable. Now, don't, like for a horse, when the horse is running and if the horse is not able to run, that horse is of no use. The owner kills the horse. You see, if the horse is not, running, do you know the owner just puts a gun on the horse and kills the horse? Similarly, if the movement is unstable, abnormal, you stabilize and stop the movement. There is no need for here and there, just final. Okay, Raghavinder?
There's a Stephen Tandian. Go ahead, Stephen. You asked to comment. Stephen Tandian.
Yes.
Thank you very
Go
much,
ahead, Stephen.
John. Hi, sir.
Hi, how are you?
Your student. Yes, Prof. So I'm fine. I've done two surgery with tear malformation type 1. I do C1, C2 fixation, and first come he cannot walk, and after 1 week surgery, the patient can walk. So it's like what I learned in KM, and as additional. Mayo Clinic published one article in GNS. In their publication, they told that patient with TRE type 1 that do laminectomy and then the compression to the occipital and duroplasty show that there is a negative correlation with the clinical feature. So they told that after doing the compression, the patient do not have a quite good result. And they proposed that maybe there is some misalignment in the C1, C2 that already proposed by my sir a long time ago. So I'm no doubt to do that surgery to my patient. I've collect in my how to say it, in my series. I hope that when it's quite good, I hope I can publish it in the future. But in my hometown, the case is not very much. It is, and they are still fair to do because some neurosurgeons think that this technique is weird and ridiculous. But I think because they not read many and they don't see what so well done, so they don't know what's the magic in came what I see. Thank you very much.
Thank you, Stephen. You have to do it, okay? You have to do it. I want you to do it, and I want to come and see you doing it, okay, Stephen?
Stephen, where are you from?
I'm from Medan, from North Sumatra.
Indonesia.
Welcome. Welcome.
Thank you, sir. I'm so pleased to can meet you again, although in online.
Great.
Thank you.
Welcome.
Dr. Omar is online. He wants to ask any question.
Okay, there's one from Raghav Dendra.
I'm with you, Dr. Atul.
Yes, how are you?
How are you?
Very good,
I'm
very
fine,
good.
and fine to see you and Dr. John and all colleagues.
There you go.
I am with you, but I wait to begin to treat with your professional about this fixation, atlantoaxial fixation, there's no material here. I am, now at north of Syria. No, all companies to bring small screws for these things. Yes.
Don't worry, I will come to your country and bring some screws for you. Don't worry, okay?
Okay, yeah, there's a question from Raghavendra.
Okay. I am ready.
Oh, I'm sorry.
We'll come in Syria.
Yes.
We will come.
From Syria, okay.
was now we are at separated from Syria to come to Turkish and come to Idlib city, you know.
Yes, yes, yes.
Okay, Raghavendra, do you have the
If you want to see me,
Oh,
not
I'm
see
sorry.
me, come to Damascus.
Okay, okay.
Okay, Omar. Raghavendra, do you have a question?
Okay.
I'll ask it if you want. Okay, I'll ask the question, Atul.
Now, yeah, go ahead, John.
You see it, right? If a case odontoid fracture is managed with C1,
This is finished. John, what will
Oh, I'm
John,
sorry. That's why, Abby, please moderate the questions, okay?
John, what we'll do is let me finish the rest of the lecture, because that is
Okay.
also very complete revolution. And then we can ask. And also I will ask whoever wants to ask question can put on the screen, and let me see if I can answer as many as I can. Okay.
Well, when the king talks, I listen.
Okay.
Otherwise, I'll be beheaded.
So now the king, listen to the revolution. Okay.
Okay.
So now we have all heard of anterior approaches to cervical spondylosis. And this is my chapter in the book, Sweet and Smidek book, which is a very popular book on spine and in neurosurgery. And this was my chapter. So I was doing a lot of anterior approaches myself, to the extent that I wrote this chapter in that book. And this kind of decompression and fixation were a common operation in my surgical domain. And also I had described these kind of tricortical screws long time ago. But now what I'm going to present to you is an absolute revolution. The revolution is that disc is not the problem. Disc needs to be, there has to be reverie, means there has to be prayers for the disc. Disc gives you movement, disc gives you shape, and disc is the master. The problem is the muscles, problem is the human standing position, problem is that we have not taken care of the muscles, and the facets become weak. These are the muscles and these are the pulley, these are the region of the facets. So facets are the problem. Disc is the master. I call disc as the ringmaster, or like of an opera, the leader of the opera is not having any instrument in the hand, but runs the entire opera. So disc is the brain, brawn is the muscle. So that is the concept, that disc is not the issue, muscle weakness is the issue, and facetal listhesis is the result. First, I will talk on craniovertebral junction degeneration. Degeneration of craniovertebral junction atlantoaxial joint is not at all discussed in the literature. When we talk of spinal spondylosis, we talk of C1, we talk of C4-5, C5-6, C6-7. We never talk of C1, C2. C1, C2 degeneration is the most common form of spinal degeneration. So you remember this. This is very important, and this can be, neglected, as I mentioned to you. So degenerative osteoarthritis is a very common issue in craniovertebral junction surgery. Now, when there is a vertical instability, muscles become weak. You see the joint space reduces. The joint space is completely reduced. This is a buckling of the posterior longitudinal ligament. There is osteophyte formation here. So these are all secondary issues. Osteophyte formation, buckling, reduction in the joint space are secondary. They are protective and they are reversible. So these are the three things that you have to remember. Ossification in the apical ligament is not an issue. It is secondary, it is protective, it is reversible. You see these osteophytes here, osteophytes here, osteophytes here, osteophytes here. So there is no need for decompression here. There is no need for decompression from front or decompression from behind. What is required is stabilization. And what is required is if you can do realignment. You see this osteophyte formation, this retro body cyst formation, os odontoideum. These are all secondary, all due to chronic atlantoaxial instability And all of them need one solution, that is atlantoaxial stabilization. And these are all secondary. And also, as I mentioned, protective and reversible. This retroodontoid pseudotumor, this was, the whole world was doing transoral surgery to remove this. The whole world was doing lateral surgery to remove this. So we introduced a very fantastic and novel concept that this is like an osteophyte. This is secondary. This is naturally protective, and this is reversible. So this is the article which I introduced about 20 years ago, where we said that this retroodontoid is not a tumor. This is not, don't do any decompression here. What you need is atlantoaxial fixation. So this is a very commonly done operation now, and very few people in the world will now do decompression for this kind of problem. This kind of retroodontoid cyst, we said that this is due to unstable atlantoaxial joint. There is no need to open the cyst. Opening of the cyst is very important, but there is no need. You do fixation, the cyst disappears. So there is a pseudotumor. What is required is understanding the fact. There is instability, clear central instability in many occasions. This cyst does not need to be treated or punctured or anything. What is required is atlantoaxial fixation. This cyst will disappear as early as in the immediate post-operative period. So we have got now several cases like this where the cyst has not been treated, and recently we have talked about this buffer system in the vertebral body. This cyst is a dynamic phenomena, and it goes inside, it goes outside on flexion and extension, and these are protective and these are buffers, and this needs atlantoaxial fixation. So there are many cases like this. Some of these cases have been treated as tuberculosis and things like that, but what is, these are secondary to unstable spine. This is a buffer in the bone. There may not be any facetal malalignment, but this is central instability. Atlantoaxial instability is the solution. So retroodontoid cyst, this is my article which you will like to read. Even we talked about retroodontoid pannus in rheumatoid arthritis. We said that pannus is due to vertical instability. This is buckling of the ligament. This is not a pathology as the whole world is shouting loudly, but this is due to buckling. You do fixation, the thing disappears. So we had introduced these spacers, and these spacers are now very commonly used. Now I will go to the next chapter. See, we have talked about craniovertebral junction and facets and things like that, but never about facets of the subaxial spine. You see, these facets are the whole muscle bulk is focused on the facet. There is nothing on the vertebral body. This is the strongest part of the bone. Facetal stabilization gives you the strength. Even the pedicle, you see, pedicles are not as strong as the facets. Vertebral bodies are not at all strong as the facets. Now, facetal listhesis due to vertical spinal instability is the cause of spinal degeneration or the genesis of spinal degeneration or spondylosis. Listhesis, which cannot be seen on very ordinary imaging. So now you carefully see reduction in the intervertebral body space. This is not primary. This is nothing to do with the disc. This is due to vertical instability. These kind of bulges in the disc are not primary. These are secondary to vertical spinal instability. This ligamentum flavum buckling due to listhesis of the facets, multi-segmental. So there is no need to do decompressions here. You come from front and remove this. You come from and remove this osteophyte. You come multi-level discectomies, and all those things are negative operations. Because if you do discectomy and you don't, the issue is unstable. And also I have to tell you, there is no compression here, but the thing may be unstable here also. So you have to know which segments are unstable and which segments need fusion. So vertical instability is the point of genesis of spinal spondylotic disease. Now, before I go to my current issue, I will give you some of my historical perspective. I was doing this operation, which I'm going to show you some years ago in the year 2010 I published this article, which is now very commonly cited, and multiple articles are there in the literature on this subject, where I am doing facetal distraction arthrodesis. You see facetal distraction using a spacer. You see this spacer? This is preoperative bulging of the osteophyte and OPL, posterior longitudinal ligament. In the immediate postoperative period, the ligamentum flavum is stretched normal, and also the disc space has come back to normal. You see new fluid in the disc. So we did several operations like this some years ago. You see ligamentum flavum buckling, posterior longitudinal ligamentum buckling. This is in the immediate postoperative period. You see there is new disc which has come up. The ligamentum flavum has now stretched. The lordosis has gone. So these are multi-segmental spaces that we introduced as a concept. The concept was instability is the issue. Decompression is not the treatment. There is no need to do laminectomy. There is no need to do corpectomy. What is required is arthrodesis and stabilization. See this posterior longitudinal, say the new disc ligamentum flavum is stretched, and I have done only facetal distraction. So I have done multi-segmental distraction. The question is instability at the facets and listhesis at the facets is the issue. Decompression is negative from front and behind. Arthrodesis is the treatment, and magical result is the outcome in the patient. Radiologically also you see the magic. There is posterior longitudinal ligament and there is a new disc. You see new disc, new water. This ligament has gone and there is no compression, and this is immediate postoperative period. Basically the result is arthrodesis or stabilization. And stabilization we have done in several cases in the past, and I will talk about what I do now after some time. You see there is instability, there is arthrodesis. That is the treatment. There is multi-segmental compression. There are multi-segmental facetal distractors, and this is arthrodesis, and you see the whole thing is completely normalized. And the patient has remarkably improved, magic. So decompression is not the treatment. And you see this is another patient where there is, we have done distraction, and there is, you see there is no compression now. So compression is not the primary issue. Issue is instability. This is secondary, this is protective, and this is reversible. So intra-articular spacers, this was a new concept, or this was a new introduction of a concept in the spine literature. And this was my article in 2011, 10 years ago, where we said that this is distraction is a treatment, and this was on the cover page of Journal of Neurosurgery. So this concept introduced a new hypothesis of spinal degeneration. And these were my spacers, and these are very heavily patented. So that is another thing. Another thing I'll show you. You see immediate postoperative reversal of disc herniation. And this is published in World Neurosurgery. You see this. There is a disc herniation here. The whole world will come and do discoidectomy, and I will agree, and I will not, argue too much with them. But you see in the immediate postoperative period after facetal distraction, the whole disc has gone inside. This is immediate postoperative. So same concept we introduced for lumbar canal stenosis, where we introduced spacers, and we did on several cases, and I published this in the year 2013 with saying that the problem in stenosis is not compression. Problem in stenosis is vertical instability, and you introduce spacers and vertical stabilization. That is the treatment. So now I go further, and I now go to my current issue. So if you realize, and all of you are spine surgeons, if not neurosurgeons, but spine surgeons, and also I will ask you to keep your questions handy, put on the chat box. I will answer when I finish. And I want to have several questions on the chat box and on the question and answers. So the whole spine surgery is focused on one issue, that decompression is the treatment. Decompression of compressed and deformed neural structures has been the basis of surgical treatment for several decades. So decompression, decompression, compression. So this is going on. So what I'm saying is decompression is not the issue. Instability is the issue, and only fixation is the treatment. So in 2013, I introduced for cervical spondylosis only fixation. And in 2020, I introduced another concept that muscle weakness related spinal instability is the cause of cervical degeneration and spinal stabilization is the treatment. So decompression is not mentioned here, only stabilization. Now I want to show you rapidly some cases. You see there is multi-segmental buckling of the ligament, and I am doing only fixation, and you see after about 1.5 years the thing has disappeared. This compression has gone and the patient will improve not after 1.5 years, he will improve in the evening of operation. Only fixation. And there are several videos with me which I will not be able to show you because most of them are in Indian language. You see this is multi-level bulge and this has completely gone, and you see what I have done is only stabilization. This is multi-segmental thing here, and you see the whole compression is gone. I have not done any kind of decompression. Sometimes I use the bone of the spinous process for arthrodesis, but there is no decompression. So degenerative cervical myelopathy, we have to look in a different perspective, with a different eye, not with the same eye. Instability is the cause and stabilization is the treatment. That eye we have to see. Decompression is not the issue. It is not neural deformation or compression, but instability is the cause of symptoms in degenerative spinal disease. So these are all the sentences which I am saying are all published, and you might like to read them. Now, most important thing, as I mentioned, it is not just compression that you see on MRI, which is the site of unstable segment. This unstable segment may be 2 segments above, maybe 3 segments above also. So what are the indicators of spinal instability? That is the most crucial thing which has to be learned and understood. So if you see this, there are 2-level problem, but I am doing 4-level fixation. So now you will ask me why I am doing upper level. So there are indicators of instability in the upper spinal segments, and that has to be understood clearly. In this particular patient, there is a central atlantoaxial instability, which I have treated by this technique, which I will talk maybe if I will talk in the subsequent part of the lecture. But what you see is, you see this compression is completely disappeared after few months of surgery. Compression is not the issue. Compression is not the problem. It comes in because there is a problem. If it goes when the problem is solved. This is a divine intervention. You see multi-segmental compression. There is nothing left now after some time, and I have not done any decompression from front or from behind. I have done only stabilization. So there are several patients with me like this, where I have not done any kind of decompression and only stabilization. Now I want to touch on another fantastic subject, another revolution, atlantoaxial instability. You see, nobody knows that in multi-segmental spinal spondylotic disease, there can be atlantoaxial instability also, and which is a very common feature. You see multi-segmental spinal spondylosis, there is no compression at the atlantoaxial region. There is facetal instability, unstable. You have to fix this one in addition to this one. You cannot ignore atlantoaxial instability in these cases. Particularly when there is severe cervical spondylotic myelopathy, atlantoaxial instability of a central variety is almost always present, and you have to include C1, C2 in the fixation construct. No decompression of any kind is the answer to this problem. If you do decompression, you just don't do decompression. So I have introduced this alternative technique, which you will like to read if you want to know as to how to do atlantoaxial fixation in subaxial spondylotic disease. Now, what you see here, there are this patient coming on wheelchair. There is multi-segmental issue and there is no atlantoaxial instability, but this is central atlantoaxial instability. I do this alternative C2-3 technique, which you must read in my article on the subject. I have done multi-segmental, and believe me, a new life, which you have not imagined. You see, we are all doing degenerative spine for lifetime. How many patients you have seen after surgery who say, doctor, I have got a new life? How many you have seen? You may have seen 1 out of 20 who will say, doctor, I have got a new life. My myelopathy is gone. I can run now. You can see, he will say, I have little bit improved, little bit not improved. But how many you have seen? They will have complete normalcy after this kind of operation. So multi-segmental issue, and with severe myelopathy, I have done atlantoaxial fixation and subaxial stabilization. This is another case. You see multi-level, no decompression, only stabilization. Sometimes I introduce 2 screws in 1 facet. So this same concept we introduce for lumbar canal stenosis. Lumbar canal stenosis is also similar. It is not stenosis. You read this article in Neurosurgical Focus, where I have written that I am analyzing the role of stabilization, and I am saying that there is a futility of decompression. You see multi-segmental bulges. These are not primary. You don't have to remove these discs. You don't have to decompress and laminectomy. This is multi-segmental instability. You have to do multi-segmental stabilization. This is multi-segmental instability. Multi-segmental stabilization is the treatment. There is no need to remove any of these beautiful natural bones, which we all remove and throw, like laminae and spinous process. There is no need there. You have to just pray. You don't have to throw these natural things which can never be wrong. So my teacher, Dr. Manu Kothari, used to tell me, in nature, there is no terror of error. Nature will never, nature knows what to do. We have to understand what we have to do. We have to do what we were not able to take care of our muscles. That is why the spine became weak, and that is why we need to stabilize. So we have got several patients and several articles on the subject where we have done only fixation, and this is very widely published, that for lumbar canal stenosis, we should do stabilization. It is not stenosis. We should not call it stenosis. We should call multi-segmental instability, and multi-segmental stabilization is the treatment. So the question is whether we should remove osteophytes. Is it necessary to remove osteophytes in degenerative spondylotic disease? So this was my article which was published, and I wish you read this article. What is the outcome after only fixation? The outcome is fantastic. All these osteophytes will disappear after 1 year. You see these osteophytes, and these osteophytes, what I have done is only fixation, no decompression. Only fixation, no decompression, and these osteophytes will disappear beautifully, spontaneously, without manipulating. These are natural, these are secondary, these are protective, these are reversible. So osteophytes, the whole spine surgery is focused on osteophytes. Do not focus on osteophytes. So spinal stenosis is a misnomer. We should not call it stenosis. We should call it instability. So basilar invagination, spinal degeneration, listhesis, instability is the cause, and stabilization is the treatment. Another thing, this kind of kyphosis, though, many treatments have been described as kyphectomy, osteotomy, corpectomy, and things like that. I am very clear that this deformity is due to weakness of the muscle, is due to instability, and it needs stabilization. This kind of deformity, there is atlantoaxial instability, you have to do atlantoaxial stabilization. This kind of deformity, this subaxial lower deformity, this is due to multi-segmental instability, you have to do multi-segmental stabilization. This kind of instability where there is central instability, you have to include atlantoaxial fixation in your construct. So only stabilization, no decompression for deformities. That is another fantastic thing. You see, don't come and do corpectomies and do all these kind of things here. You do stabilization and you see the magic. Now I want to come to a brand new subject, a subject which will make you many of you shiver, and I want you to ask questions. If you don't ask questions, it will be a little bit unfortunate and I will be a little unhappy. You have to put questions on the chat box, particularly after what I'm showing you now. Prolapsed disc. When you have a prolapsed disc, my concept is prolapsed disc is secondary to instability, secondary to injury of muscle leading to instability. Either instability is the cause of prolapsed disc or prolapsed disc is the cause of instability, and instability is the issue. Stabilization is the treatment. There is no need to remove the disc. So this is another concept which I am giving you. So this kind of disc herniation, what you will do, the whole world will come from anterior and remove this disc. I am saying this is a result of instability. It may cause instability. You stabilize and it disappears. There is no disc left here. There is a herniation, there is no disc, and this, you see, there is a disc, there is no disc, and the patient will recover remarkably, magically in the evening of operation. You try this. So facetal fixation as the treatment, we introduced this article in World Neurosurgery. Similar concept we introduced for lumbar spondylosis. You see, there is a large disc. I have not done any kind of decompression. I have done just fixation, and this disc, you see, here is the disc. This disc has disappeared. So we have got several patients where we have done only stabilization without the need for direct disc resection, and this is a possibility. Of course, this is a different possibility from what you have been doing for ages. And if you suddenly, if I say don't have to remove, you will argue with me and you will say, no, I don't believe in it because I am doing discoidectomy for ages and this is a beautiful operation. I have been also doing, but you try this and you will see a magic that you have never seen in your history of degenerative spinal surgery. So there are several patients. So this was the question, that is disc herniation secondary? I am saying it is secondary to instability. I am saying it is a protective natural response. And I am saying once stabilization is done, there is a potential for reversal of disc herniation. Now I go to my another beautiful chapter, OPLL, ossification of posterior longitudinal ligament. So you read the title, OPLL and cervical spondylosis, same cause, same treatment. Instability is the problem, stabilization is the treatment. This kind of OPLL I used to do in various forms. I introduced for the first time in the literature oblique corpectomy, which is now very commonly done in the world. This was the first article which I had published on the subject. And I used to do this kind of oblique corpectomies. But now what I'm saying is atlantoaxial instability is very commonly associated with OPLL. OPLL is secondary to unstable spine. OPLL is secondary. OPLL is protective. OPLL is reversible. This kind of OPLL, don't come and do corpectomies or laminectomies and all. Just do this Camillus technique, transarticular fixation. This is a beautiful technique of fixation. Solid, quick, and rock-like. And you see the magic. This is my article which I published several years ago. And this article I recently published on my experience. And you see the title, Only Fixation as the Treatment of OPLL. Identify central instability. And if it is present, include atlantoaxial joint in the fixation construct and multi-segmental stabilization. Decompression is not the treatment. Atlantoaxial joint is frequently involved and must be included in the fixation construct. Do not do decompressions. Do not, it is compressed, all right, it is visually compressed, but this compression which you are seeing is very difficult to remove by front. It is bone and it is protective, and don't do it. Just do fixation and see the magic. See the magic which you have never seen in this kind of surgery. So atlantoaxial and subaxial fixation, can it revolutionize the treatment of OPLL? I am saying absolutely yes. Camillus technique, transarticular, is a beautiful technique of fixation. Adopt it. Don't lose this opportunity. And I have got several articles on this subject and several alternative techniques where I've introduced 2 screws and I have introduced 3 screws in a facet. So there are alternatives. So facets are the key. Facet fixation is the strength. Can decompressive laminectomy can disappear? Can decompressive laminectomy for degenerative spine, spondylotic, lumbar, and cervical become historical? I am saying yes. Is instability the nodal point of arthrodesis, nodal point of pathogenesis for both cervical spondylotic myelopathy and OPLL? My answer is yes. Can anterior spinal surgery find space in history book like anterior transoral surgery? My answer is maybe yes. All these surgical procedures of laminectomy and decompression can become historical. My answer is yes. So from only decompression, a century-long journey has gone where there is now only fixation. So this is the solution. Now the final sentence before you, my dear young friends and senior friends, and I wish I can have many questions from you, which is the aim of today's presentation. I'm introducing a concept that compression is never primary. Concept is never a problem. Compression is a solution. Decompression is never the treatment. Thank you very much, my dear friends. Now I will await some questions from you.
Okay, Atul, I think it's working. I know it was hard. I kind of had to convince you to try to do this, but we have a bunch of questions. We'll get better as far as editing them. Abby, are you there?
Abby had to go for some meeting, so
oh,
she will
okay. Okay, then maybe you can help pick the questions out. There are more than one, Atul, which is great. I had a feeling this would happen. I have a feeling that people were kind of shy. So let me just get here. Someone asked how decreased this space is protective. How is it?
I am saying that this space is protective. It is protective because you know what? When there is a vertical collapse, the disc gives way and this itself disappears to make space for the vertical collapse, vertical because of the muscle. So this is a philosophy. This is a hypothesis. It is not. There is a question from Louis. Louis, there is a question from you. Okay.
Don't know.
Louis, you want to ask a question? I met Louis in Rio, John.
Oh, Louis. Okay, go ahead, Louis.
Louis, I cannot see you. I cannot hear you. Louis Carelli.
Oh, okay. Wait a minute. Let me let him in here. Louis Eduardo Carelli, but
yes.
Okay, there he goes. Okay, Louis, you're unmuted. Louis Carelli.
Louis, go ahead.
Okay, he's coming in. Louis is coming in now. Okay, Louis Carelli. I know he's in here.
Hello.
Okay, there you are. Okay, we're looking for you.
Thank you, Ben. Dr. Goel, our patients are very well recovered the neurological deficits we made together by Goel technique. Professor Goel do this new concept in the craniovertebral junction in our craniovertebral junction society course in Rio de Janeiro. And all the Brazilian surgeons are very helpful and they agree with these new concepts. And I have a question for you, Professor Goel.
Yes.
For the craniovertebral junction instability, when surgeons need to realign and insert a spacer, and when only need to do distraction only?
Yeah, Louis, this is a very important question. The thing is, instability is the problem and stabilization is the treatment. That is number one. Second thing is when to do distraction. I introduce distractor spacers for stabilization more than realignment. Realignment is, for basilar invagination, you realign, introduce spacers. But more than realignment, solid orthodesis fusion is more important than realignment. So stabilization is more crucial than realignment. So I introduce spacers when I want more stabilization. And when there is a remarkable, when there is bad basilar invagination, and I use stabilizers because they add to stabilization. So I recommend them.
Okay, may I give you one more opinion and a question, Professor?
Yes.
For spine surgeons, sometimes cervical alignment, it's an issue that some surgeons have a concern. I know your experience, you have beautiful cases and publications, but what you're feeling about this issue? It matters something to do realignment of the spine, or the range of the cervical, the C spine, it's not an issue for neurological recovery of the patient.
Yes, one is, like deformities, cervical deformities and dorsolumbar kyphosis. If you treat the primary issue, they can, second, like torticollis of the neck, you treat atlantoaxial, the torticollis recovers. You treat the neck, kyphoscoliosis can recover. So instability, identifying which segments are unstable and treating those segments is very important. In multi-segmental cervical myelopathy, multi-segmental, if you are doing multi-segmental corpectomies or, in any case, you stabilize, you do stabilization. So stabilization is more important than realignment. That is the answer to your question. Stabilization is more important in degenerative spinal disease than realignment. Sometimes there is a kyphosis of the neck. In the kyphosis, don't go and start repairing the kyphosis. It is secondary. You treat the unstable segment. That is more important. It is not necessary to do corpectomy and make the thing align. That is the thing, Louis.
No, I agree, because in normal subjects, 20% of the people have the kyphotic C spine.
That's right.
And
that's
if
right.
that a straight or lordotic C spine is the better choice, but sometimes asymptomatic patients have a kyphosis in C spine.
That's right. So if it is like sometimes asymptomatic patient can get Chiari malformation. Asymptomatic patients can get Siringo Myelia. So when you see Chiari malformation, you have to be careful. You should know that this patient is, he has unstable spine and he might get a problem in the future. So those patients who have kyphotic spine, they have potential instability. They may not be manifest instability, but potential instability. So that we have to be careful in a person who has kyphotic deformity or kyphotic nature of the spine. We have to be careful that he might develop a problem in the future. That is the issue.
Thank you, Professor.
Thank you,
Okay,
Louis.
Louis, I'd like to say to you that we could arrange a webcast, I'm sure Atul would agree, with your society. You mentioned that some of your associates were interested, so I'm sure Atul would agree for us to do a webcast, but we can talk about that later.
Okay, thank you, Ben.
Okay, thank you. Atul, you do that, right?
Yes, I know. We have done, I operated with Dr. Kareli, and we will organize it very soon. Louis, we should organize for the Brazilian Society, for neurosurgery and for Spine Society, we can do this.
Okay, both societies together. Okay,
yes, yes.
Okay, what's the next? You see the question there, Atul? Let's see here.
Now, this is another question, which is a very fantastic question by Dr. Bhandari. So he's asking me when to do facet spacers and when to do fixation. This is a very beautiful question. Both have been, evaluated by me, as you know, Pawan. I used to do facet distraction spacers earlier in my career, and we have published this about 10, 12 years ago. So now I'm doing facet spacers on some rarer occasions. Now I'm doing only fixation screws. So that is my current concept. Now, another concept you are asking is, what do you recommend for Corda equina syndrome or foot drops in disc herniation? So this is another issue, which is a tremendous issue. You do only fixation. When there is a disc herniation, you do only Camillus technique, transarticular fixation. And you have to just believe what you will see is a magic. And you know what? You have done fixation. Suppose your magic does not work, which has never happened to me. If it does not work, you can, like if you've done multi-level fixation or two-level fixation, if it does not work, you can come anteriorly and do decompression if it doesn't work. So decompression can be done anytime if your fixation does not work. But I have never done decompression after I have done fixation. So it is possible not to completely avoid, direct dealing with the compressive effect. It is possible.
Okay, Atutosh, go ahead.
Dr. Tripathi is online. If he can join in and ask a couple of questions. Dr. Lucky Tripathi, Dr. Harshad, if Harshad, you are online?
Yes, Atul, I am listening.
You are not listening. You have to now talk and ask some questions.
Atul, you are making a revolution, and I have to learn the revolution first.
But
we're trying a new format, Harshad, and it's working.
Yes. I like people asking Atul questions. Atul is a smart guy to give answers.
Yes,
okay, Ashutosh has a question. You want to come on camera, Ashutosh Shukla?
Yes,
he's our president.
Oh, go ahead, Ashutosh.
Go ahead.
I want to ask one question. First, I will ask for cervical spine, then I will go to lumbar spine.
Ask.
Sir,
be ready. Atul, be ready.
Yeah, ready.
Sir, according to you, you are focusing on fixation and the patient improve, okay? But on radiology, reduction will be same. Invagination will be the same. So how will we deal with this condition? Because now patients coming with film. If doctor do this and Google saying the different thing.
So the thing is, if the patient has improved, why you are bothered about the radiology? If the patient has improved, which I am saying will be a magic if you do fixation and over the period. Suppose there is an osteophyte and you have done fixation, that osteophyte is not going to disappear in one day. It will take 2, 3, 4 months. But what I'm saying is, first day you do a MRI, osteophyte will remain. But patient will improve in the immediate post-operative period. He will not ask you about any MRI and all those things. So what is important is you attack the problem, attack it strongly. The secondary effects, just ignore them. And you see how the secondary effects will return back to normal. That is what is the issue. You understand?
Okay, sir. And my second question from the lumbar spine, sir. According to you, sir, disc herniation is a protective mechanism. The buckling the ligamentum flavum is a protective mechanism. But according to pathophysiology of the disease, according to book, they are saying this is due to dehydration of disc.
Yeah. So what I'm saying is, you can make new books now. We have to now start making new books. We have to start making. That is why I use the word revolution. To use the word revolution is not easy. You cannot say I have done revolution or revolution. I am saying revolution because the whole spine, the entire books on spinal surgery and degeneration for last 50, 70 years, if you read, the entire book is saying one thing. First sentence of the spinal degeneration is that disc degeneration starts with the disc space, reduction of water content of the disc, age-related disc degeneration. So the whole concept is different now. I am saying disc is not the issue. Disc is not the problem. Disc should not be condemned. Disc can never go wrong. Disc is not the problem. Problem is you, because you have not done exercises. You have not gone to the gym. You have not run. And because you have not done exercises, your back is weak. And that is why there is a secondary effect on your spine. So that is the thing.
And sir, third question. You said just for PIVD lumbar spine, just fix the facet joint. And if this is there, and just fix the lumbar spine, spacer will improve. And you said you are using the spacer. What is the criteria for the spacer and the only fixation?
So that is the question which I have already answered. As I mentioned, I introduced spacers in spine surgery long time ago. Nowadays, I don't use spacers too often. I use only fixation. But sometimes when my fixation, I am not happy or I am not satisfied, at that point, I use spacer. Basically, spacers are used to stabilize rather than to realign. That is my current concept. So you have seen that I have said that instability is primary. Secondary, you can get osteophytes, you can get OPLL, you can get cyst, you can get synovial cyst, you can get small synovial cyst, which I have shown with example, that you don't need to touch the synovial cyst. You need to do only fixation and the synovial cyst will eventually disappear. You don't need to touch the osteophyte, they will disappear. The disc, you don't have to remove the disc, you don't have to remove the laminae and all those things. You don't have to remove all those kind of things. What you require is do a solid fixation. And that solid fixation will not be achieved by pedicular fixation and rods. Pedicular fixation is not the strongest technique because pedicles are not as strong as the facets. Movements are occurring at the facets. It is not occurring at the pedicle. So if you want to fix the facets, you have to fix the facets. If you have to stop, if there is a huge, the whole earth can be moved. If you know where is the fulcrum, Archimedes' principle, that he said that I can move the whole earth if I know the fulcrum. The fulcrum, if you stop at the fulcrum, the whole movements will be stopped. So the facetal fixation, this technique transarticular is the most beautiful this thing. Much better than pedicular fixation. You do pedicular, they don't do pedicular rod and all those because they are expensive. People want to use it. Use fantastic small screw in the transarticular camillus technique. Okay?
Yes, sir. Sir, my last question.
Arjun, you want to ask a question on camera? Go ahead, Arjun. Arjun Gupta.
Sir, can I ask last question?
Go ahead. Go ahead.
Sir, I'm a resident. Okay. For BI and the PIVD lumbar spine, what will be my answer to examiner?
That you
they are used to for the old technique.
So no, you must, for the examination, you must say the old books what they are saying. But but in the future, when you become a consultant, at that time you must say what I am saying. Okay.
Okay, sir. Thank you, sir. Thank you very much.
Okay, you're welcome.
Ashutosh, you can quote.
Yes, sir.
You can quote Atul because this is a technique which he has revolutionized.
Yes, sir.
In examiner, if I am your examiner, I will pass you if you quote it.
Thank you, sir. Thank you.
Thanks, Ashad. Okay, Arjun, are you there?
Yeah.
Arjun Gupta, go ahead.
So, with your talk, sir, what I could understand is you have just taken the natural history of degenerative disc disease as your treatment modality, because most of them are all conservative and non-operative treatment, and that is how you have laid basis for your treatment of stabilization for that degeneration. You are just addressing those micro motion instability parameters in a case of degenerative spine. I wanted to ask you, sir, while doing your facet fusion, do you completely violate the capsule, or only while just putting the screws you just precisely put the screws? Do you violate the whole capsule, or no? You preserve the capsule and just insert the screws?
See, when you are trying to fuse the facets, you want to fuse it and finally fuse it. You don't want to do it half. So what you do is you open the joint, you remove the capsule, and you introduce bone graft if it is possible. If it is possible, do it. Because you are not going half-hearted. You have to do final and fix and fuse.
Right.
There is one question from Mongolia, John.
Yes, Bayam Batson. I don't know if she can come on camera. Yeah, from Mongolia. What do you think of that, Atul? Okay, I don't think she could come on.
Dr. Goel, one question.
Go ahead.
Hi, great lecture, and I wrote this in the chat as well. Your points are very well taken and crystal clear. And you just recently mentioned how even the secondary lesions will disappear or get resolved with fixing the spine. In the case of a calcified cyst or something potentially more solid, does this argument still hold water?
Yes, yes, this holds water. You see, in the retro, in the subaxial, in the lower spine, in the upper spine, I was talking of upper spine, where the thing becomes like bone. And it becomes, they were treated as pseudo tumor and gout and all those things. And there was a operation where we were going from mouth and removing that solid calcified thing. But when I said that this calcification is not a primary thing, it is secondary, and we have got now several people are in the world are doing, they are doing just fixation, and that disappearance has been documented. That solid, I have documented on several occasions those things disappearing spontaneously. So calcified or not calcified is not the issue. Calcified is a long-standing. Calcified only tells you that the problem has been existing for months and years. And liquid is little bit, not years, maybe months, but these are all secondary issue. Osteophytes, when you see, these are related to chronic instability. See, that is one issue. Arjun, are you listening, Arjun? Chronic instability is the issue. Chronic. When there is an acute instability, the whole matter is different, like disc will herniate and things like that. There will be scoliosis, sudden and all. But in chronic situations, in craniovertebral junction and in subaxial spine, in chronic situations, there are several secondary maneuvers which happen, which are introduced by nature, protective maneuvers, including this synovial cyst, including these osteophytes, including this disc space reduction, including this ligamentum flavum buckling, including deformities, kyphotic deformities, scoliotic deformities. They are all secondary, long-standing. So when you identify these deformities, you don't jump on deformities and start removing the bones. That will be a very negative operation. What is important is find out what is the problem, where is the problem, and treat the problem. That is the answer.
Sir, there is a question from Pawan Bhandari. When and how do we select facet spacer versus facet screws in cervical spondylosis?
So you select screws. And when your fixation you feel is not strong enough, and when some old people, I have seen some very old people where the facets are completely, off, they are distracted and they are away from each other. At that point to fix, you can use spacers. So spacers can be used. Spacer is an additional mode of stabilization. So I have mentioned stabilization. If you need spacer, you can certainly do it.
He's also asking, sir, what do you recommend for Corda equino syndrome or foot drop in lumbar disc herniation?
So I have answered this question. You have to do only fixation and they have to see the magic. The foot drop may recover in the immediate post-operative phase, like you throw a ball, it returns to you. It can return to you at that speed. And that magic has to be seen and observed. You for the foot drop, you start, this is of course a very, very completely revolutionary thing to say that don't remove the disc. This is a huge statement to make, but this statement I am making in front of an international audience. There are people from all over the world on the screen at present. You understand, it is also being relayed here and then by John. So, yeah.
Dr. Ravi Ramakantan wants to ask you a question.
Yes,
Sir,
yes. Ravi, can you come on the screen, Ravi? Ravi is my senior. Ravi, yeah, go ahead.
Yeah,
Ravi.
I'm there for you.
Yes,
Hi,
Ravi.
Atul.
Hi,
Atul,
Ravi.
when you do multi-level fixations, what happens to the level above and below?
Yeah, that is the issue. That is the question. So that is, when this spine is a very magical thing. When you see osteophyte at one level and you fix at one level, we have ignored the other level, which may also be unstable. So sometimes there may be no compression seen. There may be no compression seen, but there may be unstable. The segment may be unstable. So it is not just the radiologically you see one segment which is unstable, but actually you may have more than one segments which may be unstable. And you have to fix more than what you are seeing on radiology. That is one thing. Now what happens is this spine is a very unique kind of architecture is there. There are big long muscles and there are short muscles. So there are short muscles not only do activity like flexion, extension, but they also do distraction. Their muscles are also involved in distraction. So when the muscles become weak, that the bones come closer. So now what happens is when 2 or 3 or 4 segments become weak, you have to stabilize or you have to strengthen by exercises. If you cannot strengthen by exercises and you develop secondary features and neurological deficits and all those things, you have to stabilize. Now, how many segments to stabilize? If there are 3 segments unstable, you have to stabilize 3 segments. But those are not dictated by radiology. They can be dictated during surgery also. You move the spinous process, you find unstable segments. Now, if you have done 3 or 4 level stabilization, naturally the upper levels and lower level segment can be, little bit subjected to further instability. So what we do is because now the long muscles will take care of them, the chances of instability at adjacent segment is not very high, but it is always there. So what you have to recommend is after you have stabilized, you ask the person to do exercises and come back to stability by exercising his body and muscles. That is the only thing that can be done. Ravi.
Okay, thanks, Atul. If I can ask one more question.
Yeah, please go ahead. Yeah.
In an earlier lecture, you had mentioned about what the ordinary mortals call idiopathic scoliosis.
Yes.
And you had said that it's all coming from C1, C2.
That's right.
And if you C1, C2, everything is gone.
So that is the thing, idiopathic scoliosis, we call idiopathic. But many a time, I'm not saying all the time, I'm not saying always, dorsolumbar scoliosis is, you don't find the reason and you blame idiopathic, you put the label idiopathic. But you must examine in those patients craniovertebral junction in a very elaborate fashion, and many a time you might find a craniovertebral junction C1, C2 instability. And if you have your ideas clear about the subject, when there is instability, when there is no instability. And if you know exactly that C1, C2 has to be fixed, you can avoid a very unnecessary operation on multi-segmental fixation for kyphoscoliosis. I think more often than not, particularly in younger age group, in 10, 12, 15 age group, if there is a dorsolumbar kyphoscoliosis, you treat C1, C2 and you see the magic. Ravi. Anyway, I'm happy that Dr. Ravi Ramakant could come. He's one of the senior most radiologists of India and one of the most respected teacher of the subject. And it is my honor and great pleasure to have him on my show. And believe me, that this gives me great happiness.
Likewise, Atul. Thank you.
Thank you, Ravi.
I think Ashutosh had another question.
Abhi isko band kar.
Ashutosh.
Bol. Yes, Ashutosh.
Sir, how you decide screw size? Yes, ma'am. What is your criteria for screw size decision?
Some questions you have to, think. Some answers you have to think. Everything cannot be answered. You have to think, you have to decide during operation, you have to identify this thing, you have to read the literature, you have to know from experience. So all those things are very important. Understand?
Yes, sir.
Okay. Now.
I will ask you a question now, sir. So what do you think about the future of spine surgery?
That I think John can answer. John, you think you can answer that question?
Well, I could try, but I don't think it'd be very comprehensive. I'm just glad to see a tool. I know I'm not a neurosurgeon, but I had a little background in orthopedics. It just struck me that to cure a problem, they kind of destroyed a lot of the supporting ligatures and the ligaments, and it didn't make sense to me.
You see, the issue is spine surgery is very much commercialized. And everybody wants to use these spacers and all those distractors and all those things, anterior cervical surgery, lateral surgery, endoscope surgery, and all those things are very much highly developed and commercialized to an extent. To come out of that web of commercialization is very difficult. You see, these screws are maybe not even $200, the entire operation can be done. The question is why you want to do $200 when you can do the same operation in $20,000 or $50,000. So patient, when the insurance is there, the patient does not mind $50,000 because he will mind if you are doing it $20 because he say, I am insured. Why the hell I will use your $20 operation? I will use my $50,000 operation. So that is another issue. You see, we are so much commercialized. We are in the web of commercial, disaster. Unless we get out of that, we will not be able to succeed in our work. So with those few remarks, those are not very, those are off the record remarks, but what I say, I mean, and I say it is a divine subject. We have to love our spine. We have to respect our spine. It's a gift by God. So you strengthen your spine by your exercises. You run, you jog, you muscle, you reduce your weight, and you keep your spine healthy. And if it is unhealthy, it is you. Don't blame the discs. Don't blame the ligaments. Don't blame the osteophytes. If you are unstable, you stabilize. And with those few words, I thank you all and my best wishes to you. And I hope you take this, some concepts and some views in the right perspective. You can argue in your mind, you can debate in your mind, but I will suggest you go in the literature because all these things have been published by me, and review the literature because in a short span of time you cannot come out with all the things that you have written. So you have to go to the literature and read these articles and come and become more informed about what I'm saying. So thank you very much and bye-bye to all of you.
Well, thank you very much, Atul. But you did make a mistake. You said it's your show. It's our show.
Yeah. Of course, John, you are the boss. You have done it and you have taken this message far and wide and loud and clear without any question.
Well, I'm glad that this platform worked of interaction. As you can see, we had a lot of people that really want to ask questions. And of course, I think we have to limit it to medical to start. But there were some patients that asked me, would Atul be willing to do this with patients? But we'll talk about that later.
Yes.
Okay. And anybody else want to say goodbye and parting to Atul? Okay, we had a good crowd. Vlad, are you still there? Perhaps not. He stepped away. Anyways, Atul, I guess we'll end it. We're going to stick around, and if you want to hang out.
Okay.